Aujourd'hui, nous avons le plaisir d'accueillir le docteur Erin Strumpf, qui est économiste de la santé, qui détient un doctorat en politique de santé et économie de l'Université Harvard. Elle a aussi complété un stage en santé et vieillissement au National Bureau for Economic Research et le US National Institute on Aging. Elle est professeure agrégée au département d'économie et au département d'épidémiologie, de biostatistique et de santé au travail, ces deux départements de l'Université McGill. Et elle a aussi récemment obtenu un titre de chercheur boursier junior 1 du Fonds de recherche du Québec, Santé, et du ministère de la Santé et des Services sociaux. Ses intérêts de recherche, vous allez deviner, portent sur les caractéristiques des soins de santé, des financements du système de santé et des effets de ces caractéristiques et de ce financement sur l'accès, la qualité des soins, les coûts et les résultats sur la santé, particulièrement pour les populations vulnérables. Elle va nous présenter le résultat d'un travail de plusieurs années. Et le titre est « Effet des groupes de médecine de famille sur l'utilisation des services de santé et les coûts qui y sont associés ». Alors, avec beaucoup de plaisir, je donne la parole au docteur Strumpf. Est-ce que tu utilises ça?
Oui. Merci Pierre. Merci à tous pour être venus, même aux distances. J'aimerais remercier aussi mes collègues qui ont travaillé avec moi pendant plusieurs années en fait. Donc mes amis qui étaient étudiants postdoctoral à McGill et maintenant à Carleton University à Ottawa. Je remercie beaucoup Julie Fizet-Lamiel qui était ici à côté de Maman de Diop, qui ont fait beaucoup de travail et bien sûr Dr. Tosignan aussi. Okay, so just to give an outline of what I'll cover today, to start out by describing primary care reform efforts in general and how we think about measuring the impacts of these reforms. So think of this as a conceptual framework for how we're doing this research and why we're asking the questions we're asking. I'll then move to describe in more detail the Groupe de médecine de famille in Quebec and briefly give an overview of some of the existing research on the topic. I'll highlight what I think are the contributions of this project in particular and tie that to the methods that we use and the data that we use. In the end, of course, present some results of our work and some conclusions, future directions, and questions for all of you that I hope will sort of feed the discussion at the end. So this is a quote from the Romano report in 2002 that sort of was taking stock of the Canadian healthcare system, where it needed to go, and really highlighted the promise of primary care in improving the healthcare system. So the report says no other initiative holds as much potential for improving health and sustaining our healthcare system. There is every reason to believe that primary healthcare would not only save Canadians money in terms of their future investment in the healthcare system, but also improve health and save lives. Now this is a sentiment that is shared certainly beyond Canada and developed countries around the world, that primary healthcare has the promise to do a lot of good for the health of populations and for strengthening healthcare systems. Many developed countries have implemented reforms based on this idea that primary care can really do quite a lot of good. And these primary care models tend to share certain characteristics. So as you look around different jurisdictions, different Canadian provinces, different developed countries, you'll see primary care reforms that exhibit some of these characteristics. So most often you see a team-based approach to primary care that is multidisciplinary in scope, so teams not only of physicians but of other health professionals as well. We see a movement towards rostering patients or enrolling patients in primary care practices, making sure that these enrolled patients have access to a comprehensive range of services, not only during office hours, but on nights and weekends. That primary care physicians serve as the sort of portal, the entryway, and make referrals to specialists and other social services. Often we see payment methods for primary care physicians that blend what we're used to seeing as a fee-for-service payment with elements of capitation or pay-for-performance, an integration of health promotion and prevention strategies, and the integration of electronic medical records as well. So if you look to the west, in Ontario, family health teams, family health groups exhibit many of these characteristics. We have medical homes in the US, maison médicale pluridisciplinaire in France, fund holder, GP in the UK, all sort of built on this same set of principles. So given all of this interest in this movement in primary care reform, we might ask the question, does primary health care work? And when I say does it work, meaning does it do all those things that were put forth in the Romano report? Does primary health care save healthcare systems money? Not necessarily the most important thing, but one thing that's on the table. Does primary health care improve health? The population level, individual level. Does primary health care save lives? And I'm sure you're all aware there's a very large body of work in primary health care, right? A lot of which makes comparisons between patients who are enrolled in new primary health care models and patients who see their healthcare providers in more traditional settings. Maybe that makes comparisons between countries that have more primary health care in some sense and countries that have less primary health care. Maybe compares individuals with good access to primary care versus poorer access to care. And all of this research provides interesting descriptive evidence to help us understand how those patients or those countries compare with each other. What I'm going to argue is that if we really want to answer this question, does primary health care work, we need to change our framing a little bit and ask whether changes in primary health care affect population health, mortality, utilization of services. So this changes is going to come up again and again, and I think is quite important. The reason why I think this is the interesting question to ask is, many of us coming from a health background or a medical background came back to randomized trials as being the way we'd like to measure whether something is effective or not. So if we could imagine designing a trial to evaluate whether primary health care worked, we would probably take two groups of patients. We would collect lots of data on them before. We would randomly assign some of them to receive new, better, more primary care. Others would receive the usual care. And then we would collect more data after the intervention. We would essentially be changing the primary health care received by one group while keeping the other group's care constant. And we would be making the assumption that that control group was a good counterfactual or good measure of what would have happened to our treatment group in the absence of primary care. We can think about this, stepping back from primary care for a second, in the context of other exposures. So many of you may be interested in social determinants of health as well. The same principles hold true, that we have many studies that ask whether, for example, people with more education are in better health than those with less education, without asking the question whether intervening to change the educational status of individuals or populations would change health outcomes. So, basically saying if we had a policy that reduced high school dropout, if we had policies that made university education more accessible, and we changed the amount of education that, like, say, for example, the Quebec population was receiving, would that have an impact on health? So that question is not only of interest to people who are interested in social determinants of health, but I would argue is actually the same question that policymakers want to know the answer to, right? Policymakers may be considering interventions or may have already implemented policies, and they want to know whether that intervention caused a change in population health. I hope you'll agree with me that actually creating a randomized trial to evaluate primary health care or education and their impacts on health is unlikely to happen. Fair enough, for lots of good reasons. It's also probably true that if we could create a trial, it wouldn't really give us the answer that we want to understand whether a policy that's put in place and then lets individuals make their own decisions in the real world, sort of the restrictive conditions in a trial wouldn't necessarily be a good way to study that. So setting aside the randomized trial, we looked at observational studies and recognized that many designs don't really have the ability to control for lots of confounding factors that would bias our estimates. And some of these confounding factors are observed in our databases, and that's great, but not all of them. So as with all observational studies, we worry about bias. Particularly because of these exposures that we're interested in, people are not randomly assigned to different levels of education. So there are many factors we observe or not that would affect that. And in the primary healthcare context, in the Canadian system, we don't obligate physicians to join new models of care. We don't obligate patients to do so. So physicians and patients choose what type of model they'll work in or receive care in to a large extent. Some observational study designs, you may have heard of natural experiments or quasi-experiments, do allow us to take advantage of changes in the exposure, changes in primary health care or education, and to mimic some of the strengths of a randomized trial. And so that's the kind of study design that I'll be presenting today. And basically what we're doing in this project is evaluating the impacts of the Groupe de médecine de famille. So this helps us, answer the question for decision makers and researchers and the public. What did this particular policy do? What are the impacts of this particular intervention? But I'll also say that because the implementation of this policy created a change in primary health care in Quebec, we can use evaluating this policy to understand in a broader sense, does primary health care work? So to answer that broader question. And I think investing more in this kind of policy evaluation gives us better answers to inform evidence-based policy making in the future. Okay. So to give a little bit more detail, many of you are probably very familiar with these Groupe de médecine de famille, but this is a policy that was implemented in late 2002 in Quebec. A GMF, a Groupe de médecine de famille, consists of about 6 to 12 full-time equivalent physicians. Those physicians are working in close collaboration in a team setting with nurses and perhaps other health professionals as well. The actual form and function of different GMFs across Quebec is quite variable. That we have about 1,000 to 2,000 registered patients per full-time equivalent physician in a GMF. And about 10 years after implementation, we had 239 different GMFs across the province. About 55% of family physicians were working in these groups, and about 36, about a third of patients in the province were enrolled. Now, this study that I'll present to you today really includes data from the first generation of GMFs. So this is the 79 GMFs across the province who began between 2002, end of 2002 and mid-2004. Nurses are thought to really play a key role in these team-based models, right? So they'll be more responsible for doing things like patient interviews and screening, following up with patients about taking their medication or coming back in for another visit, and disease prevention and health promotion. The GMF signs a contract agreeing to provide additional services like extended hours access in exchange for some additional public funding. A key point is that physicians maintain the same paiement à l'acte, that whether they're in the GMF or their non-GMF counterparts. So there's no real strong change to the payment of physicians. This is very different, for example, from the case in Ontario. GMF physicians do receive a small per patient per year payment. So this is $7 per patient per year for registering patients in the GMF. And there is some additional funding for being available after hours. If you compare these sorts of financial incentives with those in Ontario and other contexts, they're very small. They're there, but they're small. Okay, so the goals of the policy in very broad terms were to improve access to primary care, to try to ensure that every Quebecer has access to a primary care physician who would provide continuous services across the sort of range of clinical services. The idea was also to increase complementarities and ties to community services provided by CLSCs and to specialists as well, and in general to improve the provision of primary care and its quality. What I'll present to you today is our investigation of the impacts of these GMFs on healthcare utilization and costs. So just briefly to describe what we might expect to see given the policy. So the whole point, right, is to improve access to primary care. So we would expect for utilization of GP services to go up in the GMFs relative to the non-GMFs. For specialist physicians, it's a little less clear which direction we would expect. If primary care is doing a really excellent job of disease management and we coordinate better so there's less duplication of services, we might see fewer visits to specialists. On the other hand, if patients have better access to GPs who provide referrals to specialists, we may see more. On the emergency department side, we worry that there are many people seeking care in the emergency department because they don't have access to primary care. So if we improve access to primary care, we would expect decreased utilization of the emergency department. And for hospitalizations, which we also look at, but I won't discuss in detail today, it's a little unclear. It depends on how many hospitalizations we think are really avertable by better primary care. So on the cost side, it's mostly similar. We expect an increased use of GP services. As we continue to pay on a fee-for-service basis, this should increase the cost to the Quebec healthcare system for GP services. On the other hand, we now have these teams of providers. We have nurses whose salary is not as high as physicians. So if you think there's some substitution going on, costs may stay the same, could even go down. With specialists, because our prediction about use is uncertain, our prediction about cost is uncertain. And for emergency departments, if we do see a reduction in utilization, we may expect a reduction in cost as well. Okay. And so briefly, to put our work in context with the large body of work that already exists and continues to be built on, looking at new primary healthcare models, I would argue that the medical literature, the public health literature, health services research, tends to examine specific dimensions of care So for example, looking at the performance of the primary healthcare system in terms of accessibility, continuity, patients' experiences of care, all of which are very, very important to look at. We also have contributions by a few folks in this room as well as others, looking at sort of classifying primary care organizations into a taxonomy and then assessing how they perform relative to each other. Most of this work is descriptive in the sense that, again, comparing performance in some types of primary care settings versus others, as opposed to really digging in on changes in primary care. The economic literature tends to takes more of that causal framework, but really focuses in on how are physicians paid. And that's, the economists tend to take that. And so, aren't necessarily interested in continuity or patient experience, but more how are they paid and how many visits do they produce. There's very little out there looking at implications for the broader healthcare system, right? So of course, we are interested in improving accessibility, continuity, quality, and health outcomes. We also want to know what's happening to the number of services being provided, the types of services, and the costs. So we're going to contribute to this literature by using a quasi-experimental design to answer that causal question: what are the effects of changes in primary healthcare delivery on outcomes at the healthcare system level? So we're trying to say from the ministry's perspective, what happens to these outcomes of utilization and costs. More specifically, we're estimating the impacts of these first-generation GMFs in Quebec on utilization of healthcare services and the associated costs. And we're taking an intention to treat framework where we look at the registration of patients at sort of a time zero, a starting point, whether they're in a GMF or not, and then follow them through time to see how the policy affects them. So I think the key methods that allow us to say that we are getting at this causal question, there are four key pieces here. One, that we observe outcomes both before and after the GMFs come into effect. So if you think back to that randomized trial, you collect data before and after the intervention. We use a propensity score analysis to try to address selection bias that's a function of things we can observe in our data. So I'll show you, we know based on the policy that participation is voluntary, both for patients and physicians, and I'll show you some of our work that could tease out what some of the factors are that affect participation. We use statistical methods for data that are very far from normally distributed. And we also use a control group to address potential confounding on factors that we can't observe in our data, that we don't measure in the administrative data. And as I describe our methods in more detail, it's going to follow the same four points. Okay, so the data that we use is called our cohort database and was originally conceived, put together by Pierre Toussignan and colleagues at the ministry with the express purpose of evaluating the GMFs. So we have administrative data from the RAMQ Medeco databases on about 800,000 vulnerable patients. And we have data that spans the period from 2000 to 2010. So a vulnerable patient is a patient that has had this vulnerable billing code billed by their physician to the RAMQ. So this means essentially that they're elderly and or they have a certain list of chronic conditions. So these are more, both the RAMQ considers them vulnerable, and as a researcher I would consider them more vulnerable in terms of their health status, more likely to need and to use more healthcare services than a younger, healthier population. So a little over 100,000 of these patients are registered in a family medicine group, a GMF, and about 700,000 are not. For each individual, we have 7 years of data. So we have 2 years before they are registered as vulnerable and 5 years after. The vulnerable registration happens at the same time point as being registered in a GMF or not. In addition to the healthcare utilization data, we have some geographic, socioeconomic data as well in the administrative databases. So the administrative data, of course, is just a record of every bill from physicians to the RAMQ. So we have to transform this record of all these services provided into something that makes sense to us in terms of visits to a physician, hospital admissions, and the costs associated with those services. So we aggregate those individual clinical acts based on the date and location of service into things that we would recognize as a physician visit, an emergency department visit, a hospital admission. The outpatient and emergency department costs are directly available in the database. Inpatient costs for hospitalizations, we base on the niveau d'intensité de ressources, utilization, anyway, it's an indicator weight for the admission based on the sort of diagnosis of the patient and some of the services used. So the NIRU is available in the data, and the physician services billed during a hospitalization. We multiply that weight by the average cost per NIRU from the ministry. It's worth remembering that in the RAMQ data, we have physician-billed services and hospital admissions, nothing approximating everything we would think of as primary health care. So services provided by nurses, psychotherapists are not in our database. And we do have some data on prescription drugs, but we're not including that in this analysis. We also take out of this analysis individuals who die during our follow-up period, who enter long-term care, move to a different type of region in Quebec, or who live in the very far north. So they're not included in this analysis today. Okay, and so in terms of our outcomes that I'll present to you today, so we're looking at the number of GP visits. So this is the number of visits per year with a family physician, whether that occurs in a private clinic, a CLSC, whether it occurs with the patient's family physician in an emergency department. This apparently happens more often in more rural regions of Quebec, so we wanted to include that. The number of visits to a specialist is the same. Number of visits per year to a specialist physician, regardless of the location. For costs, we're looking at the amounts paid by the RAMQ in each of those categories. So GP costs and specialist costs. And at the end, I'll also present total cost measure. So this is going to include GP costs, specialist costs, and also inpatient, so hospital costs and emergency department as well. Okay, so remember that I mentioned, we know that enrollment in the GMF is voluntary, the decision to work in the GMF is voluntary. So we started by doing some work looking at the data in those 2 years prior. What characteristics predict whether physicians join these models and whether patients join these models? So we found that physicians who had more diverse clinical practice were more likely to join GMFs. This diverse clinical practice is really a function of where they practice. So physicians who joined GMF were more likely to see patients in lots of different types of settings. They were more likely to be younger in the sense they had fewer years in medical practice and were less likely to be in urban centers. Patients who enrolled in a GMF were more likely to have a low socioeconomic status, to have some chronic conditions like diabetes and congestive heart failure, and were more likely to visit the emergency department for conditions like asthma or diabetes that we would consider sensitive to how much ambulatory or primary care they receive. They were also less likely to reside in an urban region and less likely to have a usual provider of care measured by sort of a concentration index of the number of visits to a given provider. So this is all before they joined the GMFs. So based on those factors, we suspect that a naive estimate that didn't account for those differences might underestimate the effect of GMFs on health and might overestimate the effect on utilization because patients who are more likely to join tend to be sicker. So we create propensity scores. So we calculate the predicted probability of joining a GMF based on the patient's characteristics, and use that to use a method called inverse probability of treatment weighting, which allows us to control for selection based on those observable factors. So we end up restricting our sample to GMF patients and non-GMF patients in the same distribution of the propensity score, and then use this weighting technique. So this just shows you the distribution. These are our GMF patients, the distribution of their propensity scores between 0 and not quite 1. And the blue on the bottom is the non-FMG patients. And you can see that they really overlap quite a bit. There are a few GMF patients who, based on their characteristics, have a very high probability of actually, the statistical model says, oh yes, this person would definitely join the GMF, but there's no comparison group of non-FMG patients who have the same characteristics. So we don't include these few people in the analysis. Okay, so that's our selection on observables. And this is graph showing the number of visits. This is total outpatient visits in 2 years before and 1 year before their enrollment. You can see that just in the raw data, the non-GMF patients tend to use about 1 more visit on average than the GMF. Patients, after we use this weighting technique based on the propensity score, they're much more similar before they enroll. So sort of more comparable. And we can look at their demographic characteristics, other measures of utilization or health status, and they look much more comparable to each other after the adjustment by the propensity score. So moving on to this very skewed, non-normally distributed data that we have. So this table on top shows average utilization in the pre-exposure period, and the bottom is the post period. So this tells us the average number of visits to a family physician in the 2 years before enrollment is about 5 visits per person per year. There are some people who do not have any visits, and there's at least one person in the data who has 190 visits to a GP. And this is very typical, actually, of healthcare utilization data in Canada and the US and the UK. So it's very, very skewed. You have some percent of individuals who don't use any services in a year, and you have a few people who use a lot, right? So especially if you look at 70% of people don't use the emergency department in a year, almost 90% don't experience a hospitalization. So from a statistical perspective, we need to, this is not a nice normal distribution, but we need techniques to work with these data. But again, it's just worth remembering, so think of 5 GP visits a year as the average, about 4 visits to a specialist, half an emergency department visit, and 0.15 hospital admissions per year. It goes up a little bit in the later time period, but not very much. Because costs are a function of utilization, of course, we see very similar patterns. So average spending per year per person on GP visits is $152. Again, some people spend nothing because they have no visits, and some people spend quite a lot because they have many GP visits. So you can see, here too that the average is usually larger than the median because there are those people very far out spending quite a lot. So, quite impressive numbers for very expensive services like hospitalizations, but if we just look at the average, $942 on hospitalizations. So to deal with these very skewed data that are over-dispersed, have a lot of mass at zero for some variables, we use population average estimators using our panel data. So we use negative binomial models for utilization, generalized estimating equations for costs, and robust standard errors to account for the fact that we observe the same person many times and that those observations are not independent. Okay, and then lastly, the question of adjusting for unobserved confounding, right? Again, we want to try to go back to that idea of a randomized trial. So we're going to use something called difference in differences regression models, and this is a technique that's used very often for policy evaluation in a range of different fields. The basic idea is to compare changes over time for our GMF patients with the changes over time for our non-GMF patients. Again, same idea as the randomized trial. You follow changes over time in your treatment group with changes over time in your control group. Of course, our patients are not randomized, but it's what we've tried to just deal with. So basically, this is a simple multivariate regression, including fixed effects for our two groups, our GMF and non-GMF, and our year fixed effects. So each year we observe in our data. So those group fixed effects help control for any differences between the two groups that are constant over time. And those could be factors that we observe in our data or unobserved factors. So one example, I told you that we know that our GMF patients are less likely to live in urban areas and more likely to be in more rural areas of Quebec. So that we observe in our data. But because it's more or less constant over the period we look at, it'll be controlled for by our fixed effects. And maybe there's something sort of correlated with that. Maybe one group has sort of healthier lifestyles, they walk to work more often, they're more concerned about what they eat, those things we don't observe in our administrative database. But if they stay more or less constant between the two groups over time, we're able to adjust for those. Our year fixed effects control for common time trends. So any changes over time that are shared by both the GMF and non-GMF patients. So think about any secular trends across the province in access to services, because of other types of clinics that may be implemented, any changes in medical practice that occur across the province and affect both groups. One particular point here, remember that we have registration as a vulnerable patient at the same time that these patients are being registered in the GMFs, but that's also happening for our non-GMF patients, right? Everyone in the sample is being registered as vulnerable at time zero. So any sort of shared, any changes that occur as a result of being registered as vulnerable that affects both groups is going to be controlled for by our control group. And then we do add in a few observed control variables to help adjust for other differences in observed factors. So I showed you these graphs before, just with these first few data points. This is just looking at the raw data in the database, what's the average number of visits in each year. This is the pre-period and the 5 years after. The red line is our non-GMF. The blue line is the GMF. So it might be, you could easily say, well, 5 years after GMFs are implemented, those patients have fewer visits to a physician than those patients not in the family medicine group in the GMF. But I would say, well, but they had fewer visits before they enrolled in the GMF as well. So when we use the propensity score to weight, and we look at the trends over time in the two groups, you can more easily see that they were about the same after weighting in the pre-period. The non-GMF group increases its utilization more than the GMF group does. So they both go up a little bit over time, but the GMF group less so. And that's really going to be the key to our analytic strategy, is to say, what's the relative change for the GMFs versus the non-GMFs? So they may both go up over time, but the GMF group less so. Okay, so I think more or less on time. So that's the basic idea. So we run these fairly complicated regressions that take a lot of computer power and take some time. The coefficients, the output from those models, tell us something about the direction of the effect and the statistical significance, but they're fairly difficult to interpret directly. So what we do is we use those models to predict utilization both before and after for our GMF and non-GMF patients. So this is our predicted number of visits to GPs after the propensity score weighting, after controlling for other covariates. So we estimate that GMF patients have about 4.2 visits before and 5.1 visits after GMF implementation. So their number of visits to a GP goes up by 0.96. The non-GMF group has an increase of 1.52 over the same period. So we just take the difference between these two numbers and see a negative 0.55. So our estimate is that GMFs reduce the number of visits to GPs by 0.55 visits over those 5 years of follow-up relative to the non-GMF group. So that's our estimate of the effect. What is 0.55 visits? It's sort of a strange number, but to put in context, so we said, well, how many visits does the average person have over 5 years? So it's about 26. So if we divide 0.55 by 26, we see that the difference is about 2%. Right, so we say it's a relative reduction of 2% in terms of the number of GP visits. Going through the same process for the number of specialist visits, we estimate that GMFs reduce the number of visits by 0.15, or about 0.7% over 5 years. We do the same type of analysis for costs, so we can see again for the predicted cost for GP visits for the GMF patients, it's about $132 before they enroll in GMFs and about $190 after. So those costs increase by $58. And this is constant dollars adjusted for inflation. Non-GMF patients spent about $131, so very close, very much the same in the pre-period, increases to $208. So again, the difference here is $19. So we're estimating that GMFs reduce the cost of physician visits by about $19 per patient over 5 years, relative to the pattern in the non-GMF patients. So again, we say, well, how much did the average person spend on GP visits over 5 years? It's about $980, so see sort of the same magnitude of effect. Reduction in cost is also about 2%. For specialists, it's about 1%. So, small reductions in utilization and costs associated with GP visits and specialist visits. This led us to ask, okay, well, we're looking over 5 years. So is the effect getting larger and larger over time? Is it staying the same over time? And what we see is that really the impacts of the GMFs on GP utilization and costs occur in the first year that they're enrolled in the GMF. So this graph on the left shows relative costs, and you see this big drop in relative costs in the first year. And over here, we just look at our predicted average costs for the two groups over time. And the key here is that before enrollment, the GMF patients cost a little bit more. And then in the first year, these lines cross, so that by the end of the first year, they cost a little bit less. So, you know, if you look at the rate at which the red line is increasing, the blue line is quite a bit slower. So there's that big drop in relative costs and this crossing of these lines of average costs. And what we estimate, we saw changes of 2%, 1% over 5 years, but in the first year, we're estimating that the GMFs reduce the number of GP visits by about 10% and cost by about 14%, using the same methods that I showed you before. And then in years 2, 3, 4, 5 of follow-up, the effect persists at least relative to the pre-period. So in the pre-period, GMF patients spend a little bit more, and in the post-period, they continue to spend a little bit less. But we don't see any more sort of drastic reductions in their relative use. And we don't, over time, this difference between them gets smaller and smaller. So that seems to be the trend we're seeing. Okay, and then this is the last graph on total cost. So again, this includes costs for GP visits, specialist visits, emergency departments, hospitalizations. Again, over 5 years, we estimate a relative cost reduction of about $79, which is about 1%. Again, the same pattern. The relative reduction is largest in that first year after enrollment. And that's a cost reduction, total cost reduction of almost 7%. And again, over the remaining 4 years of follow-up, the total cost of the GMF patients and the non-GMF patients sort of come back together. So by the very end, there's no difference between them. Okay, and then in thinking about these costs, we see some sort of relative savings among GMF patients based on their utilization of services. But we have to remember that the government spent money to implement this policy in these GMFs in the first place. So we don't have very detailed data, but we do the best we can with what we have. So we use data that's originally coming from the ministry and was published in a Cyrano report looking at the average spending by the ministry to implement a GMF each year. And so these are things like paying the nurses' salaries, paying for the computerization, training, project heads, etc. We also got the number of patients registered in the GMF who were vulnerable from the ministry and applied the fees, the forfait that the physicians can charge for that registration. So we sort of calculate these fixed costs and these registration costs. Because our estimates of the effects that I just showed you are only among vulnerable patients, but of course GMFs enroll vulnerable and non-vulnerable patients, we try to attribute some share of these costs to just the vulnerable patients to accurately compare it with our effect measure. So we attribute 40% of the costs of implementing the GMFs to the vulnerable patients based on their share of service use based on the Montreal RAMQ data, so comparing how much vulnerable patients in GMFs use in terms of services relative to non-vulnerable patients in GMFs. So we estimate that the cost of implementation and maintenance per vulnerable patient over 5 years is about $76, and compare that to that relative reduction in total costs attributable to the GMFs of $79, and so a net cost reduction per vulnerable patient of $3 over 5 years. By my measure, that's neither good nor bad. I mean, it just is what it is, right? So what we're spending to create this model, let's just say, is more or less matched by changes in utilization. So to summarize what I've told you so far, right, we find that GMFs do reduce cost and utilization of GP and specialist services related to non-GMF patients, again, among a vulnerable patient cohort. The impacts are really most notable in the first year after GMF enrollment, and those effects generally decline somewhat over time. So after 5 years, we see much smaller differences between the two, and no additional relative reductions in use or costs occur. The GMFs also reduce total healthcare costs, again, largely in the first year. By 5 years of follow-up, no difference between the groups is evident, and those relative cost reductions are largely offset by the costs of implementing and maintaining GMFs. So the first question to sort of feed the discussion period, remember that I told you we expected the number of GP visits to go up, right? Access should be improved. And so this decrease in GP visits is not what we expected to see. Upon slight further reflection, we said, oh, but GMFs have nurses, and nurses don't bill the RAMQ, and so visits to nurses are not included in our database. So we're trying to think of ways where we could assess how much of a substitution effect there is between physicians and nurses in GMFs. Unfortunately, our administrative data aren't very helpful in that respect, but if other people have ideas, they're very welcome. Some other lessons we've learned from this exercise, right, that an interdisciplinary collaboration to answer these policy relevant questions using administrative data is not only possible, but actually pretty productive, I think. I should note it's not only interdisciplinary in the sense we have clinicians working with economists, working with health services researchers, but we're spread between universities and the direction de santé publique and other, so really quite a lot of collaboration between researchers and bringing in decision makers and clinicians as well. These collaborations do, however, require significant time. I think Pierre mentioned this is a work that's gone on over many years, which is how long it has taken to get these databases up and running. A skilled and experienced team with the administrative databases that we've been very lucky to work with here at the BSP. Having the necessary methodological expertise to analyze these data and the clinical expertise to interpret the findings is important, and of course, technical and financial resources, right? So now that we have these databases up and running, we understand them well, we know how to use them, we can actually answer a range of questions much more quickly than we could have at the beginning. But being able to do that really does require maintaining access to data, data updates, maintaining the human resources that we have in the team, and funding to pay them. They like to be paid. And currently we really do struggle with how to access data in a timely way. When policymakers ask questions and they'd like to get an answer back relatively quickly, it's hard to give an answer if it takes several years to access data. So it's worth thinking about some approaches that are used elsewhere, looking at Manitoba as an example, Ontario as an example, to bring together data resources, skilled data analysts, knowledgeable clinicians, policymakers, to keep that team maintained and able to tackle questions that arise as they come up. Ultimately, we're interested in trying to understand which models and systems of healthcare delivery provide the most health to patients, the most health to populations, while still making efficient use of society's resources. So what I just presented says something about how much has resource use changed as a result of GMS. What I haven't told you about, right, is how much has health of populations changed, how much has health of patients changed. So that idea that we okay, we saved $3 per patient over 5 years. I don't know. I mean, if we made the population a lot healthier, then that's super, you know, and if we didn't do anything for the health of the population, then, but, you know, $3 alone is not the number you want. So some of the health and quality measures that we already are planning to investigate, and some of this is well underway, looking at the impacts of GMFs on continuity of care, both between providers and over time. Looking at the effect of GMFs on both hospital admissions and emergency department use for these ambulatory sensitive care conditions, again, those chronic diseases that we think if they're managed well in a primary care setting, we could reduce hospital and ED use. We're also looking at the effect of GMF's team-based practice on adherence to guidelines for preventive care services. There are other measures, of course, right? Timeliness of access, the coordination and the extent to which care is focused on the patient, quality of care, chronic disease management, other types of health outcomes that we would like to evaluate and set against that change in cost, that change in resource use, to say really how much more health are we getting for the change in resource use. So these are just some ideas, and we would certainly love to hear more from all of you in the discussion about what outcomes you think are important to evaluate. What would tell you whether GMFs work better than other types of primary care organization. Okay, and then reflecting a little bit more on the shift, the reduction in outpatient utilization. Does this reflect, real decreases in use, or does it reflect shifts in the types of services or the personnel that's providing the services? I think whichever of these two is the case, we need to evaluate the implications for patients' health and experience, and for providers' experience, work satisfaction, et cetera. So thinking about other data resources, again, we don't have number of visits by non-physicians in our administrative databases. So how might we use other data or other study designs to help get at this question? And another question you'll be answering today to help us out is reflecting on what types of clinical and organizational changes we think are happening in GMFs that would help explain this pattern over time that we see, where this big reduction in use happens in the first year after enrollment and then not very much after. And reflecting on, once we know what they are, could we continue them over time? Would that be wise in terms of patient health? So that's it, and I think I left just enough time to... So again, I'd like to thank Pierre Tissignan and Eric Latimer, who were co-investigators